we can start. And, it's pleasure and honor to be with Dr. Scott again, talking about the mentorship on behalf of the SIOP Supportive Care Network. And I'm so happy to have our SIOP friends from all over the world joining, and from all the networks we got support. And thanks to the advisory committee at the Supportive Care Network for having the chance to present such a great project that is going to have a great impact on I think the mentors and the mentees to be, or like the supposedly to be mentors, and the early career pediatric oncologists and other young SIOP members are going to benefit from such a program. I think we will start with Dr. Scott. So Dr. Scott, we all know Dr. Scott. I don't need like to introduce, because he's has been like a mentor for generations, and I think it's a great start for our project, our mentorship project, to have Dr. Scott as a start. And we will start with globalizing and democratizing mentorship in pediatric oncology. And at the end of the session, I'm going to share tips regarding the mentorship project, enrollment, and how to apply, with some tips from the Supportive Care Network Advisory Committee. So Dr. Scott, I think the mic is yours right now.
Excellent. Well, and somebody please keep an eye on the new people who are in the waiting room to make sure they get let in. Thank you so much for developing this, Ahmed. It's such a pleasure to be with you all. And this is to set up the project. And then at the end, Dr. Kamal will talk about how to join. And I encouraged him to democratize and globalize the mentorship process. So there's always 3 or 4 or 10 people that everybody knows, and those aren't the mentors you're looking for. You're looking for the mentors that you couldn't find anywhere else except right here. So I would like you to keep that in mind as we go forward. And the first thing is that we all need a mentor, because nobody is an island. None of us can be fully successful by ourselves out there in the Sahara deserts. And so we all need a mentor. The question is how to find that mentor and how to make the relationship as helpful as possible. So why do we even use the word mentor? If you actually go look this up, it's a word that's common to all languages, but it came from a couple thousand years ago from Greek mythology, when Ulysses was out on his adventures, and he entrusted his son's education to his old friend whose name was Mentor. So when people said, "Oh, he's a mentor to me," they meant he's acting like this guy Mentor, who literally was a friend of the father, almost like we would say Uncle Mentor, who's such a close family friend that he's almost like a surrogate uncle or father to take care. So it has an educational role and a nurturing role and a protection role and everything you could think of, very similar to what we would hope our senior person would do in our career. So here they are. There's Mentor and the son of Ulysses, but for privacy reasons, we'll always be careful. And I thought this was fun from Wikipedia. What is a mentor and what does a mentor do? And so it's really nice. And what is mentoring? So they say, well, what community do we even want to be? So, in other words, a mentor, the idea is you help somebody become a good thing, right? So, what is a good thing that you want them to be? Also, make useful tests like failure as awesome instead of failure as something that destroys your career. We either fail and learn, or we succeed. So we can succeed and be happy, or we can fail and learn and be happy. Let's take it. So we can't just expect new people to just know something, as they walk in the door. So they need mentoring and support, teaching and learning. And the main thing to learn from all this is that mentoring is not one single activity or one single thing. Mentoring is a process and a relationship. And so, what does a mentor do? There are 4 things, especially, that I expect out of a mentor. And the next slide is actually 4 things I expect out of someone who is a mentee to that mentor. So, a mentor is a problem solving partner. A mentor is someone who should challenge us, who will tell us the truth, and who will let us take the credit. They're not there to get work out of us so that they can take the credit. I love this. Are we too busy to improve? So the invention of the wheel actually was prior to the invention of mentoring. But you can imagine a situation where we're just so busy, we can't imagine trying to spend some time to learn a new way to do things. And we might just keep using a square wheel all this time when maybe a mentor is coming here to say, hey, I got something better for you. Yes, it'll take a few minutes to change it out, but after that, your life will be better forever. Here's another example of someone who's not ready to receive mentoring. So, what does a mentor expect out of you? One is, hey, mentors can help give you courage to take action, but you have to take the action. Mentors can provide directions, but you have to make your way, follow a path, make your own path. You actually don't even need to know your mentor very well. They could still be very useful to you, even if you don't have a very close personal relationship. And certainly you won't always agree with your mentor. That would be really strange if you did. So here are two of my mentors. And in fact, why do I bring these two? Because when I went to St. Jude as a resident in 1995, I went there for my obligatory 1 month cancer rotation. And Raul Rivera was my first attending on the service, and Ching Hon Pui was my second one. And both became lifelong mentors and friends. But but they could have still been great mentors, even if I hadn't stayed at St. Jude for 20 years after that, even if we hadn't become friends and colleagues. We could have still had a good mentoring relationship, and we still would have. My plan when I met them actually was to go do primary care in a rural jungle type setting. Sorry, I shouldn't reveal their names. So I love this paper because it says suggestions for articles of authors of medical articles. So in other words, this writer here, Pericles, also is a great Greek name, very famous person in Greek history. And so Pericles is recommending suggestions for medical articles. So in other words, he's being a mentor to us. He's trying to guide us and support us. And so here he describes how to write a medical article. And so he lists advice number one, advice number two, advice number three, advice number four. And so I typed it larger here so that you could read it. So these were practical suggestions. One, follow the instructions, do not digress. Write simply and concisely. Use the best words, express your ideas, effectively deliver your message. So what is wrong with this mentoring that we're getting from this author? And please type it in the chat. What is wrong with this mentoring? I'm watching the chat. You should be able to quickly name 5 things. One thing. Ooh, to not disagree. That's good. Thank you, Lorena. What else is wrong with this? Okay, so he's giving instructions, so that could be considered good, right? But the instructions are too general. So I like what you're saying, Momboy, because these are instructions, but obviously follow instructions. Of course, we're going to do that. Do not digress. Well, how do you not digress? What exactly does that mean? Write concisely. Well, how do I write concisely? What would be, the ways to do it? How do I pick the best words? How do I effectively deliver my message? If I already knew how to effectively deliver the message, I wouldn't need to be reading a paper about how to do this. Oh, yeah, too prescriptive. Thank you, Maureen, and need to help the person what it means, right? Exactly, Laurie. So you say, well, do not digress. Well, exactly what does that mean? And I'll tell you what it means, and you won't find it in this article. I read this book called How to Write, and it was the most phenomenal book. I mean, just a short book, but the guy wrote multiple versions of it because he was an academic person, not in healthcare. I forgot. I think he taught sociology or something. But he basically wrote this book about how to write because writing is a very important part of everyone's career in healthcare, in everything else. Knowing how to write persuasively, a persuasive email, a persuasive CV, a persuasive manuscript for publication, a persuasive grant that convinces them they should give you the funds. So writing persuasively is really important. It's fundamental. And in fact, I have a friend who was recently telling me she's looking to hire somebody, And she said, I read 60 CVs, 60, and only found 5 to go to the phone interview. And I said, well, how did you, and I said, well, it sounds like, did you spend 60 hours? That's like an entire week of your life reading through 60 CVs. She said, no, not at all. You open the first page, and if there's typos there and the person is rambling on, then that's a no. That's not somebody I can hire for this particular position because I need somebody who has clear communication. So she was able to eliminate 40 out of the 60 just in 1 second. Like open the first page, said, oh, I see typos, I see disorganized, I see there's not nice section headers. No, can't hire this person. So imagine if you knew that. You're making your CV and you're about to send it for a job that maybe you really want. Maybe some of these people don't care about the job, so they put no effort into it. But some of them might need that job, might want that job that she's offering. I assume they would because they did take the trouble to put in a CV through human resources. There's usually multiple steps to log in, to upload stuff. So they did some work. But what if they had just done 1 extra hour of work to spell check the first page, actually, to spell check all the pages, but to spell check all the pages and to make that first page very appealing, very clear, very concise, very direct. Exactly, your job wants this, I am this. Your job wants that, I am that. And really tie it so that when the person opens it, they say, ah, this is the one I can at least bring to the next step. Maybe you'll hire them, maybe you won't, but at least they'll make it to the next step. And I was feeling bad for the 55 people whose whole application was discarded within minutes or even seconds of being opened because they didn't do all these things because they didn't know how or they didn't put in the effort. Now, if they don't put in the effort, okay, that's on them. But what if they just didn't know how important that CV is or the first page of the CV? Maybe they need a mentor. So obviously, my colleague won't be their mentor because she'll never have a chance to meet them because they got screened out. So this author was trying to mentor the whole world by writing this paper, and he ended up with 25 suggestions. 25. So imagine, you know, here's number 6, here's number 11, 12, etc. And each suggestion here is the whole thing. A paragraph full of numbers makes reading unattractive. But look what he did here. He wrote a whole paragraph of advice. Look at this, all this dense paragraphs of advice. And so, techniques of great mentors. Technique number 1. And part of the reason for this course, and the reason I was so happy to be the first speaker in this course, is that everyone who wants to receive mentorship should also learn how to be a mentor. And some of us might become a mentor even before we find a great mentor. And that's okay, because the techniques of great mentors can be learned on our own or can be learned with our friends, learned with our family, learned by coming to meetings like this. And the first technique is to lead by example. If you don't do it, how do you expect someone to follow you? And I will give you an example here. So, Jinghan Pui, my friend and mentor for many years at St. Jude, and my second attending there, he once after I took a job at I was a fellow at St. Jude, and I had had an abstract, and I wanted to submit it to the ASH meeting so that I could go to the meeting and present my abstract. And he read the abstract, and then he looks at me and he says, "Abstracts are nothing. The paper is everything." And he said versions of this hundreds of times during my 30 years of knowing him. But this, the first time he said it was very impactful because what I thought was he's not going to let me submit this to ASH. He's not going to let me go to ASH. And he said the abstract is nothing. It won't help anyone. Nobody will read it. Nobody, maybe a few people will look at your poster, but nobody will believe it and nobody will read it because the paper is everything. A peer-reviewed publication changes the way we all do healthcare. An abstract changes nothing. And he said, not only that, one time I wrote an abstract, I submitted it, and somebody else published my idea as a paper before I published my own idea as my paper. So he said, not only is an abstract nothing, of no value to society, but also it opens you up to the opportunity to not have a chance to even publish your own idea because somebody else published it first. Now, in his case, his paper was accepted, but in a lower journal, because whoever comes out first with the idea is the one who's going to be in the higher journal. So, this piece of advice, now for free. You're getting this advice from Dr. Pui, even though you might have never even met him. And that's great because a great mentor leads by example and leads through other people. So, what a great mentor he is if he's mentoring you indirectly through me. That's like a double blessing if you know, oh, you helped Scott, and then Scott helped Ahmed. And next thing you know, who's Ahmed going to help? I don't even know. Hundreds of people over the next, 50 years of his career. We'll see. Or maybe we won't even see. Maybe I'll be gone by then. But that's okay, right? Because the benefit of the mentoring will go on and on. So please remember this. The abstract is nothing. The paper is everything. So I was really disappointed because I thought he wasn't going to let me go. And I said, look, I'll just level with you. I wrote this abstract because I want to go to ASH. I want to stand in front of my poster. I want to have fun. And then he gave me the second piece of advice, which I hope you guys can appreciate also. He said, fun is okay. And then he signed the paper and let me submit it. And so I thought how great these two pieces of advice are when they're hand in hand. The abstract is nothing, the paper is everything. But fun is okay, right? There's nothing wrong with standing in front of your poster. And he said, but you better make sure that before you arrive to ASH, you've already submitted the manuscript for publication. Because if someone else publishes this idea before you do, then it's going to hurt your career and be very disappointing to me and to him as my mentor. So fun is okay, but the right kind of fun, the fun after you've done the work. So the paper was about lumbar punctures, and it was my first paper that I wrote at St. Jude. And why am I telling you this? Because I think it's better for you to have a specific example than to have general ideas. Why? Because here I was criticizing Pericles for writing a paper with 25 general ideas about how to write. He's not leading by example. He's leading by a bad example, writing a bad paper about how to write a good paper. It's never the way to teach people how to write a good paper. So I wanted to give you a specific example of this paper because it was about lumbar punctures and traumatic lumbar punctures. And why? Because in the old days, we did lumbar punctures in newly diagnosed patients with leukemia. Now we know better. Now we know to defer the first lumbar puncture should never be done on day 1 or day 2 or day 5. It should be done either on day 8 or day 10 or day 14 after clearing all the blasts from the peripheral blood. So we didn't know that when this is 25 years ago now, and we didn't know that we should defer and delay the first lumbar puncture. Now we know it's actually terribly wrong to do a lumbar puncture when the patient has circulating blasts. And I'll show you why. So this actually is a nice clear. You don't see any red cells. You just see leukemia, CNS3. And here's a patient with, you just see leukemia cells, no red cells, not a traumatic puncture, CNS2. And here you see no leukemia cells. I took this picture myself by just making a big white box. So here I'm mentoring you about how to prepare slides. You don't have to find a picture if there's nothing in it. You just make a white box, no problem. And here is a bloody lumbar puncture. And what is the definition of a bloody lumbar puncture? 500 red cells or more per microliter of CSF. So you can tell just by glancing, this is terribly bloody. These are not even leukemia cells, these are epithelial cells. So this was the worst lumbar puncture anybody ever did. It might have been me, I don't even know. But could have been anybody, could have been any of us. We've all made the mistake of doing the lumbar puncture and going too far till we hit the spinal cord on the other side. So here's this paper, my first paper at St. Jude, Risk Factors for Traumatic and Bloody Lumbar Puncture in Children with Acute Lymphoblastic Leukemia. And you see here, my mentor and senior author, Dr. Pui. And what we learned is this, and I hope you never forget it because it's a lesson in mentoring and a lesson in how knowledge changes over time, and we have to keep alert for the changes. So number 1, lead by example. Number 2, admit when you're wrong. If you want to be a mentor, if you want to receive mentoring, being able to admit when we're wrong is powerful. It's a superpower. Because think how hard it is. Think how painful it is. Nobody wants to be wrong. And if we are wrong, that's bad enough. We don't want to say we're wrong. And if we say we're wrong, it's bad enough. We don't want other people to realize we're wrong. But the ability to just own it, to say, I was wrong, I'm sorry, I changed my mind, I repent. And it's interesting, the word repent, we usually associate with religious repentance, like he was doing a sin and he repented. And, every religion has this idea, right, of we do what's wrong and we repent. But it turns out repent actually means the word itself means to think in a different way. Because if we think in a different way, we behave in a different way. So if I'm doing the wrong thing and then I repent, it means, first of all, I think in a different way. I think that's wrong. I got to do something differently. And then I do the other thing. So we used to think that we should do a lumbar puncture, a diagnostic lumbar puncture in everybody with suspected leukemia to assess the status of their spinal fluid. And then we did the same thing. We did a marrow and a diagnostic lumbar puncture. And then we got all the results back. We said, oh, they have leukemia in their marrow. They have leukemia in their spinal fluid. Now we know their marrow status and their CNS status. But now I've got to start the treatment. So I enroll them on the protocol, and then I do my first therapeutic lumbar puncture to inject intrathecal therapy. So we thought we were so smart. We do a diagnostic lumbar puncture and a diagnostic bone marrow. And then we do a therapeutic lumbar puncture with IT therapy, and then we start the systemic chemo. Wrong, 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 wrong. We should have never done a diagnostic lumbar puncture, and we should have never done a therapeutic lumbar puncture when they still had leukemia circulating. And now I'll show you why. When we had that strategy, right now, St. Jude is on the total 17 protocol, and this was on total 11 and 12 and 13. So on total 10, 11, 12, 13, this was the strategy, 2 lumbar punctures. And if you did a second lumbar puncture one day after the first lumbar puncture, this was common, really common, because on Tuesday, the patient shows up, we do a lumbar puncture, we do a bone marrow. On Tuesday night, we're reviewing the marrow, reviewing the lumbar puncture. Wednesday morning, we say, oh, yep, you have acute lymphoblastic leukemia. Here's the protocol. Wednesday afternoon, time for your therapeutic lumbar puncture, one day later. And it turns out these lumbar punctures on the second day, 80% of them had blood in them. 80% were traumatic. And it wasn't because the doctor was terrible. The same doctor who did the first one did the second one. It's just because you do a lumbar puncture one day later, and what do you find? You find that blood has been leaking into the spinal fluid all day long after your first lumbar puncture the day before, even if that first lumbar puncture was purely crystal clear, zero red cells, zero white cells. Even then, 80% were positive on the next day because after the lumbar puncture, inevitably blood will gradually leak into the spinal fluid. And if you have leukemic blasts circulating around in your blood, they'll leak in there too. So what we didn't realize, and now we know, is that this double lumbar puncture early on was just a way to introduce leukemia into the spinal fluid. Worst idea ever. And yet we all did it. Even my mentor, Jing-Han Pui, the most famous ALL doctor on the planet, even he was doing it this way. We all did it this way because we didn't know any better. And if you did the second lumbar puncture 2 or 3 days after the first one, 6 times the odds of finding blood in that puncture. 4 to 7 days, 3 times the odds. 8 to 15 days later, 1 to 2 weeks later, look at this, odds ratio of 2, 2 times the odds. So the only way to get back to the risk that you had before of a traumatic or bloody lumbar puncture was to wait more than 2 weeks. And here's the first lumbar puncture, odds ratio of 1. And here's if you wait 2 weeks. So what we learned from this, that I'm only now able to articulate because it finally clicked, is that you do your first lumbar puncture and the patient gradually bleeds for 1 day, 2 days, 3 days, 4 days, up to 15 days, bleeding leukemia into their spinal fluid. And so it makes perfect sense now that we know this, why we want to delay our first lumbar puncture. And the people who delayed it the most, the first, were the Japanese. And they said, forget day 1, it's day 8. After a week of steroids, now we do day 8, first lumbar puncture, day 8. And then even better was the Taiwan study that did 10 days of 4-drug therapy in induction. So they did their first lumbar puncture at day 10, and they had spectacular results. And so this is what we all need to do now. This paper could never be published again. Why? Because now we're not going to do a first lumbar puncture till way later when it doesn't even matter. Because does it matter if you have a traumatic lumbar puncture if you've already cleared out the circulating blasts? No, it does not matter. So this is a paper that ran its course. We learned our lesson, and I hope nobody will ever do this study again because there should be no data, because we should all be doing our first lumbar puncture on day 10 of a 4-drug induction when there are no circulating blasts. And if there's still circulating blasts on day 10, wait till day 11, wait till day 12, wait till day 15. So the third thing, so mentoring number 1, lead by example. Mentoring number 2, be ready to admit when you're wrong. And be ready to admit when maybe you were right at the time, but you're wrong now because the data changed. We learned what we did wrong back in total 11, 10, 11, and 12, and fixed it in total 14, 15, 16, and 17. And now the whole world should be doing delayed first lumbar puncture. I hope most of you already are, but if you're not, please start tomorrow. If you have a new patient with ALL or AML, wait a week and then wait another week if you have to clear all the circulating blasts. So the third thing, in addition to leading by example, is leading by work ethic. And so why do I say this? Because I want you to see this paper, how painful it was. Oops, how painful it was. Somewhere in here is how painful it was. Here's where it's how painful it was. It was 5,223 lumbar punctures that I reviewed one by hand, typing it into an Excel sheet and then analyzing it. Even worse, these 5,000 lumbar punctures were done in 900 patients. 900. And these 900 patients, many of them had been treated years ago. I came there in 1998 to do this project. Many of these patients had been treated in the 80s, in the 1983, 1985, 1990, 1995. So some of their patients' charts were 20 years old. They were in a warehouse. And so I had pulled them out of the warehouse to do the study, but they had gone back to the warehouse in the meantime. And the reviewers of this paper said we need one more piece of information from every single lumbar puncture in every single patient if we're going to accept your paper. So I went there to Dr. Pui and said, hey, good news, bad news. Good news is they liked most of it. Bad news is they want one more piece of information on 900 patients and 5,000 lumbar punctures. So I said, here's my response. I responded to everything. And the response to that was, sorry, it's not feasible. And he said, it is feasible. You can do it and you will do it. So I really didn't have so much of a choice. And I'm glad now because he forced me to do it. And I kind of wanted to do it, but I didn't really want to do it. But I had to order those charts from the warehouse. And one Friday, 6 p.m., I remember it very well, my pager went off. And for the young people, a pager was a device that we used before we had cell phones, a small box that would beep when somebody called it, and then you call back the number that was displayed there. So it beeped, and I called, and it said, hey, this is Bob. I'm down at the loading dock. I've got a delivery for you. So I thought, okay, delivery. So I went there, and it turned out it was in the loading place where they load all the medical supplies, all the boxes of chemotherapy, the boxes of gloves and syringes, every kind of large boxes. And this guy had a cart, but I don't mean like a little push cart. I mean like a cart the size of 2 tables with wheels, gigantic wheels, rubber wheels this big. And it was piled 2.5 meters high with charts, with boxes. And I said, what the heck, what is in these boxes? And he said, no, these are the charts you ordered from the warehouse. And where do you want them? Because I got to take the cart back. And so he went with me to my place. I had a small office. They barely fit. We unloaded for the next hour. We unloaded. They piled from the floor to the ceiling. They literally filled the whole office. I had a maybe 30 centimeters to get from me to my computer in my chair. So I was highly motivated to review these charts because I couldn't move my chair. I could barely move my arms. So I was first started with the chart that was blocking my elbow and opened that box and did those charts. Then the next box, the next box, the next box. And what Dr. Pui said is you can and you will. And how do I know? He said, because as a fellow, when I was exactly in your stage, clinical fellow, every day seeing patients, every weekend seeing patients, every night seeing patients, on call every third night at night in the hospital, I routinely would review 20 to 30 charts for my projects. And how do I know it's true? Well, first I know because he's a very honest person. I can't remember any time Dr. Pui ever told a lie to anyone when I was observing. So I totally love that. So again, lead by example. Tell the truth, even when the truth is painful, even if the truth makes you look bad. It's so powerful, a superpower, telling the truth no matter what. But I have to admit, I didn't really believe him, even though I thought maybe he's sort of telling the truth, but he's exaggerating, or maybe he's remembering things differently. And it turns out a year later, I was working on a project, and it was a kidney stone project, and I needed an article from this journal, from Urology Journal. And the Urology Journal, we didn't have online for it. So I went to the library to ask the library, hey, can you get this journal for me, this journal article about kidney stones in children with cancer? And the librarian said, "Oh, you don't have to if it's Dr. Pui's article." So every article published by anyone from St. Jude is always in a binder by year and by first author. And so 1986, I went there and I opened the thing and I flipped to Pui, to the P section, and I found Pui. And I was looking for this article, and I found an article by him. It wasn't this one. And then I found another one by him. It wasn't this one, and another, and another, and another. He had published 12 papers in his first year of fellowship while he was also seeing patients every day. And he said, no, I don't need to see patients till 6:30 in the morning to review all their lab work and go visit all the patients. So I come early and review 20 or 30 charts to do projects before I see the patients. And so I basically saw the proof that he had actually done exactly what he said he did. So he said, you can finish this in 1 month. 30 charts times 30 days, that's 900 patients, and you'll be done. It took me 2 months, actually, but I was inspired to try to finish it in 1 month, and very inspired by all those charts piled up in my office since I couldn't move around or get to my cabinets or anything. So leading by example, telling the truth, and inspiring people by your own work ethic, great mentors. I'm going to skip this, except to say, have you ever had somebody say, well, I did 2 cases this way and it worked out fine? And you know in your mind, you say, that just sounds wrong. Anybody could get lucky twice. So 0 problems out of 2 tries. So a very common thing is a surgeon might say this because maybe you're not operating on 500 patients with a rare problem. But if you've done 2 cases and it's good results, it's encouraging. I'll do the third case the same way and maybe I'll get a good result. Or if I do a lumbar puncture, and let's say I have a new way to do a lumbar puncture where I close my eyes and I just stick the patient with my eyes closed. And what if 2 times it really works very well? Then I might say my new procedure called blind lumbar puncture. I'm going to publish this 0 problems out of 2 attempts. And so I love this paper, classic paper from 1983. Fourth tip of mentoring. The truth is permanent, eternal. So true things like always tell the truth, admit when you're wrong, lead by example, lead by hard work. These are permanent truths. Data might change. The interpretation of data might change, but certain truths are universal. So the data about lumbar puncture, we thought we were so smart to have the most experienced person do the lumbar puncture, but we were so stupid because they were doing it on the wrong day. No matter how experienced, they were still letting blood and leukemia leak into the spinal fluid after that lumbar puncture. We should have waited 10 days. We should have waited 14 days. We didn't know that. So what changed is not to have a good person do the lumbar puncture. What changed is when to do the lumbar puncture, new data. But this idea of this truth about if nothing goes wrong, is everything all right? 1983, and the mathematical way to say this is interpreting 0 numerators. And so what am I talking about, 0 numerators? Well, we showed, first of all, that the first lumbar puncture, it really mattered if it was traumatic. It worsened the patient's prognosis. But even doing the first lumbar puncture when it wasn't traumatic also worsened their prognosis because just from doing it. So what we also learned, though, was it did not cause complications, serious complications like spinal hematoma. And we had 6 lumbar punctures, which were done at a platelet count of 1 to 5,000. We had 23 lumbar punctures done at a platelet count of 6 to 10,000. 0 of these 6 had a spinal hematoma. 0 of these 23 had a spinal hematoma. 0 of 170. 0 of 234. There were 0 spinal hematomas out of 5,223 lumbar punctures. So zeros, but the question is, what is the confidence interval for complications if you observe 0 events? And if you say 0 out of 6, there could be a complication rate as high as 40%, and you just got lucky It didn't happen the first time or the second time or the third time. 23 lumbar punctures, there could be a complication rate as high as 13%, and you just get lucky. Now, here's the good news. If you do 170 lumbar punctures in a certain situation, platelet count 11 to 20,000, and you don't see problems, the complication rate still could be up to 2%, and you wouldn't see a problem. But the good news is, when you get into the hundreds, you can start trusting a zero in the numerator. So lead by example, always tell the truth, admit when you're wrong, admit when you find out that you're wrong 20 years later. Still time to admit it. That's why I'm telling you the findings of that paper now are completely irrelevant because now we are delaying the first lumbar puncture. So here's a third mentor I had. I met this mentor in the Boston airport when I was traveling. And you see how long ago this was, first of all, because no gray hair. Second of all, because I had a beeper here, the old-fashioned device for communication. And I met this guy and asked to take this selfie with him. And he had this beautiful shirt. Guess how many beers it took to build this? And I thought, well, here's a man who loves research. But we shouldn't have to guess, right? Because I said, well, how many? And he said, the trouble with my project is by the time you finish the experiments, you don't know how many it was because he did not have a database. So my fifth piece of advice is collect good information. No matter what project you're doing, if it's how many beers it takes to build this, do a good database, no matter what. A good database will save you infinite pain later. So one thing I did have with that lumbar puncture project, I had a good Excel sheet. It was very exactly built, exactly how I needed it to be to do that project. And Excel is still useful. Paper is still useful. Resonance, my organization, has a terrific database for patient care. It's fantastic. REDCap is useful. There's so many great ways to do data collection now. The only one that I don't approve is guessing. So my sixth piece of advice is how to show a slide. Okay, very nice slide, nice picture, but what are we talking about when it says this? You might not know what he's talking about. What if I didn't have this pointer here? So you want to say exactly what are we talking about. The other thing is contrast. If I put a yellow arrow on top of a gray shirt, it's not very good. If I put a yellow arrow on top of his dark blue pants, no problem. But it might be even better to do red arrows so I have contrast everywhere so you see what I'm talking about. So why am I mentoring you on how to make a slide presentation? Because my very first example was how to do written communication, how you how you write a paper, how you write a curriculum vitae, a CV, how you prepare a slide also is part of your communication. So these are critical, because if you show bad slides that nobody wants to see, you turn off the audience, they go to sleep, there goes your chance to help them benefit their patients. So leading by example, I'm not just telling you make a pretty slide. I'm showing you what is an example of a pretty slide and how do I make it. This one is already good because it's funny and it shows me in the past. So you connect with me as a person. So it's funny, it's colorful, and it's real. It's true. It actually happened. And I really did ask him about his experiment because I thought it was hilarious, his shirt. And I'm showing by example how to make a slide and how to make an even better slide. So I'm not just telling you, hey, use red arrows, they're better. I'm telling you why. Make high contrast visual things where you don't need a laser pointer because you never know where you're going to be and the laser pointer doesn't work. So back to mentorship. How are you going to find a mentor? And how important is it to find a mentor? And do I need more than one? I'll just answer this right now. You can find one through this program. So thank you, Dr. Kamal, for organizing this program and SIOP for endorsing this program as part of the SIOP Global Health Network. The education group is designed to connect people, intentionally to connect people. And my idea is it's very important to find a mentor, and we should all have more than one. Why more than one? Because you never know which mentor might be the one who gives you the critical help for something specific in your life. And also, you never know which kind of mentor. We all think, oh, I need a research mentor. I need a patient care mentor. Yes, definitely you do. But what if your patient care mentor? Wouldn't it be nice if you had a nurse to be your mentor in patient care? Because the nurse is going to have unique perspective, even if, let's say, you're a doctor. So I'm a doctor, but I think I had several nurses over my career who really were mentors to me, mentors about patient communication, mentors about how to explain about chemotherapy in the roadmap, mentors about how to deal with a difficult patient that I was having trouble communicating with. So these mentors led by example, led by honesty, admitted when they were wrong, showed their data, showed their work. So more than one and more than one kind. So how can I find a mentor? I think the best way is to do a project. I never would have had Dr. Pui as my mentor if I hadn't done the project with him. And so a project-specific mentor, we later became personal friends and sort of a all-round life mentor. But not every person needs to be an all-round life mentor, right? You could have a project-specific mentor who's very good at research and writing papers. Or you could have a life mentor who's maybe not even a mentor for specific projects. So you could work in the same place. It's great to have a local mentor that you can see in the hallway. And this is so great to have Dr. Pui and Dr. Rivero there. You could make direct contact with somebody through this program. You could make contact through friends, or you could work through this network. So mentors also can connect us with resources. And what is the best resource? The best technology? Put it in the chat. I want to see if you're still awake. And I'm doing a technique on you called getting feedback. And it turns out anytime you can get someone to actually move their body, it's a way to engage people. So if I can get you to just type something, to move your hands and type, or to turn on your microphone and speak, then that's a way to engage people and to help them listen better and understand better. So I'm asking you to type in the chat here the most important technology to improve patient care. Because we all want mentors in patient care, right? Come on, you can do it. Open that chat and type. Number one, come on. Unless the chat is locked. If the chat is locked, somebody please speak up. Ahmed, that's exactly what I thought somebody would say. Thank you for putting that there. What's up? And why what's up? Because it's like email plus a phone plus a database. But yes, communication, communication, communication. Thank you. Thank you all. AI. Thank you, Abu. Very good. Yeah, so there's lots of really great technologies, but number one is right here, the human brain. And you can have WhatsApp and you can read there, but if you don't think about it, it's never going to work. And number two is any kind of communication device. I use this picture of an ancient telephone from the 1990s, but of course, WhatsApp would work on any telephone more modern than this. So the brain plus communication, that's it. And you guys nailed this. Communication, communication, direct contact, patient communication, AI. So exactly right. Thank you for your answers. Should I have more than one mentor? And to answer this, which is our last question, we have to answer this question first. Why should I look for a mentor or do anything else related to academic activity? And the answer is because I want to save my patient's life, right? If I could save a life, wouldn't that be the best reason to do anything? I want, yeah, exactly, Dinashin, to save, get guidance. But basically, why do I want the guidance? I want to save their life. Why do I want the next steps? I want to save their life. And why do I want different mentors? Because maybe different mentors will help me different ways to save my patient's life. I think this is the only reason for anything. And every now and then, we also might want to try to improve people's life. So if we could save and improve lives, then we've really done what we wanted to do. And I bring this up because some people think, well, if I get that person as my mentor, I'm more likely to succeed in my career. So, in other words, I need to use that person to step up the ladder. And if that person can help me up the ladder, that's a good mentor. And I want to really erase that idea somehow. It's impossible to fully erase, but I'd like to try for us to erase it from our own brains, the idea that I'm looking for a mentor so I can get ahead in life. We're looking for a mentor so that we can help our patients get ahead in life, have more life and better life. And if we're looking for that kind of mentor, we're going to find the right mentor. If we're looking for a mentor so we can climb up higher for our own self, then I don't think there is a mentor of that kind, because that kind of mentor is very self-centered and selfish. They got where they are by climbing over other people. And if you're looking for that kind of mentor because you want to be that kind of person never cares about you. Doesn't care about your success like Dr. Pui cares, like Dr. Ribeiro cares. So finding the right mentor means finding a mentor who will help you do the right thing in your life, which is to become a better doctor, a better nurse, a better pharmacist, a better scientist, to improve care. And so saving lives and improving lives, that's the key. And I wrote this paper with Dr. Ribera, who was one of my other first week at St. Jude, two great mentors who stuck with me for life and are still with me. And we wrote this idea together, which is the reason why people don't get cured: no diagnosis, misdiagnosis, refusal and abandonment, toxic death, relapse and cure. And I said, hey, Dr. Ribeiro, we need to write a guideline of how to prevent abandonment, and a guideline about diagnosis, and a guidance about toxic death, and about missing the diagnosis, and so on. And he had, as he always does, great advice about life and about everything. And he said, hey, Scott, don't just write a cookbook and say, here's a cookbook, colleague, just read my book and do it. He said, help them become a chef in their own kitchen. And this has really been my motto for the last 25 years is not so you say, hey, person, do what I did or do what I think is best. But no, you're a chef in your own kitchen. It means you can see what ingredients you have. You have the experience, the knowledge, the mentoring to put those ingredients together and to make a great meal. And if somebody says, oh, suddenly the kitchen has no more tomatoes, well, you figure out another way because you're the chef in your own kitchen. Whereas if I give you a cookbook and it says put a tomato in there and you have no tomato, you don't know what to do, right? And what I had told Raul is, no, we need extra cookbook about if I have no tomato, what do I use? Carrots. If I have no carrot, what do I do? Therapeutic substitution if people don't have mercaptopurine. He said, you can never write enough books to cover every situation. People need to be the chef in their own kitchen. And of course, it's exactly true. And that kind of truth is eternal and permanent. A chef will know all the reasons for non-diagnosis and will be able to deploy the panel of strategies. The chef will know the reasons for misdiagnosis in my own place, in Memphis, in Spain, in Armenia, the places where I work, or in Egypt, or in Ghana, or in Nicaragua. The chef will know the problems here and know how to cook the food. And so the other thing I love this Israel said, look, if you have data, publish a paper. Don't go looking for more data, right? Do the project in front of you. Don't go looking for some other stale bread crust when there's a piece of cake right there for you to take. Take it, eat it, enjoy it. And part of that was he was saying, publish all of these results that you have. Don't let these results be hidden. And just like Dr. Pui, the abstract is nothing. The paper is everything. It's okay to have fun, but you better write that paper. And so mentorship in pediatric oncology, going from here to here to here to here. All of this is a process that involves, in my own life, dozens of mentors. How we're going to solve every problem by having thousands of chefs in thousands of kitchens making their own solutions to save lives, to save more lives, to save more lives, to save even more lives, and to keep saving lives, and to even let our mentees save lives and improve lives. That's what it's all about. And so that's why I was really glad to start this series. And I want to finish with this idea, which I found 10% of what we read, but 95% of what we teach others. And the last tip from Dr. Pui, he said, I don't read, I write. And I love that because what he was saying is, well, after I write a paper about something, I never forget. After I've written a paper about thrombosis, I know everything I need to know about thrombosis. Never forget. After I write a paper about lumbar punctures, I know about lumbar punctures. Never going to forget it. So if we can read something, it's great. If we can listen to a lecture like this, it's great. If we can see some slides, great. If we can see and read, Wonderful. We're up to 50%. If I could have met you in person and get you discussing these ideas, we could get up to 70%. If you could experience some of these things, if we could teach somebody else, and by this, I mean the person teaching. So I'm getting 95% out of this. I don't know what you guys are getting, probably 20, 30, 50, or 70, but I get 95. But if we write a paper about something, you've got that thing. You are a true expert by the time you write a paper. So I want to invite you to the many networks where you can find mentors. SIOP is the umbrella for this, but of course, we have an acute leukemia research and care network that's got, this is an old slide. We now have 1,100 members here, adult and pediatric leukemia doctors. We have a drug access and quality network, which is designed specifically to help people find access to high quality medicines. And many, many more. In the Global Health Network, there are many different networks within SIOP. Here's one of just a whole network just about high-dose methotrexate research and care. And you'll never see a network that I design that doesn't have research and care, because this is like chocolate and peanut butter, milk and sandwich. These always go together, research and care. The care makes the research great, and the research makes the care great. And then Archie Blyer. Where did I find Archie Blyer? I've known him for many years. I met him at SIOP, actually, and I met him because we were at a very crowded room. There was no place to sit, and there had the lunch boxes, and so we had our lunch box. And I saw him sitting. He was just sitting on the floor with his back leaning against the wall. And so I just went there and sat on the floor with him, and we were eating our lunch and talking. And next thing you know, years later, we made together this methotrexate research and care network. And here's Archie, 82 years old, on his birthday, giving a lecture about the Capizzi strategy of methotrexate use. And so I thought, what a great way to spend your 82nd birthday. He woke up at 6 a.m. He lives in the West Coast of the United States. So 2 hours earlier than me, I was up at 8 a.m. And people coming, though, from Japan, it was 10 p.m. So he gave this lecture on his birthday. It's recorded. I hope you'll all go watch it. And he talked about Robert Capizzi, who died in 2015. And he said, Robert Capizzi wrote to the Children's Oncology Group and said, please take my name off of your protocols because you're doing it exactly the opposite of how we studied and how we proved. And the way you're doing your Capizzi methotrexate is you're doing it in a way that will nullify the effect of the methotrexate. So please go watch this session because it's just life-changing. And my last piece of advice is to never write a book. Wrote one book in my life, and here's the honorarium I got, 96 cents, because the book sold 3 copies. So I spent 1,000 hours of my life writing this book. And if I could be Dr. Pui now, I would say, the abstract is nothing. The paper is everything. A book is nothing. A paper is everything, because people can go to PubMed and find your paper. People might not buy your book, but you at least you'll make 96 cents. So that's good. And then the final thing is Raul said one time there was a terrible patient who had terrible care, and we received the patient in the third relapse. And everybody was so sad for this patient and so angry about what that first doctor had done. And then Raul says human development is a process. And this is a process that he himself is undergoing. I'm undergoing, you're undergoing, we're all undergoing this process of human development. And so I want to undergo it together. This is the SIOP Global Mapping Committee. All 5 of these have volunteered to be mentors in the program. Here's the slide I took when you guys were coming in the room. I hope some of you will volunteer to be mentors to each other, because mentoring is a team sport, and as a team together, we can join the SIOP Mentorship Project and connect with each other. And now I'll turn it over to you, Ahmed, to say exactly how we're going to do it.
Sorry, Ahmed, we cannot hear you.
Do you hear me?
Yeah.
Yes, now.
This is great. Thank you, Dr. Scott, for this opportunity to start the launch of our mentorship project, which the mentorship initiative is under the SIOP umbrella. And thanks for the Supportive Care Network for being supporting this initiative to start. And please, Anelia, can you share the slides? So we will just take 3 minutes for the audience to give just a snapshot about the mentorship initiative and how are we going to start it. And because actually, like, I think like probably like some people are asking how are we going through this. So the second slide, please. So mentorship is, so as we know that this International Society of Paediatric Oncology is like connecting all of us together, and our aim is a global collaboration, education, training, research, and advocacy. And we think that that the SIOP Mentorship Project supports structured, personalized mentorship relationships, which is going to be between volunteer mentors and mentees, and will connect like people globally together. And I think this is such a great opportunity to get to know each other. And as Dr. Scott mentioned in the lecture, we are democratizing and globalizing, getting connected together, and that's the main target. So the second slide, please. So mainly our objectives in this project is to provide young physicians with personalized mentorship, foster a supportive network for young physicians within the SIOP community, promote collaboration, leadership and development, and career advancement. We all have career concerns as early pediatric oncologists. We could probably get the benefit from asking, sharing, whatever, like work-life balance, concerns in research, concerns in future steps. I think this is going to be such a great opportunity to connect with mentee. Let's go to the second slide. So what are we going to offer through this mentorship project is we're going to pair physicians with experienced mentors based on the needs, interests, and career goals, and not pair is like pairing or pairing just it will be very simple. Like there will be applications for mentees and there will be applications for mentors, and then the pairing will be through an advisory committee depending on the interests, the matching, and the needs of the mentees and the experience and the mentor's application. So we will encourage knowledge exchange and professional development. There will be regular interactions and feedback. We are going also to monitor the progress and evaluate the impact of the mentorship program on the participant skills and, of course, the patient care practice, because, of course, there will be regular meetings between the mentors and the mentees. So we can go to the next slide. So what are we expecting is to have, there will be, so since the origin is the Supportive Care Network, so there will be bi-monthly webinars. So that's in the Supportive Care Network. We do it. We experts deliver the concept of mentorship in career and research. Also, there will be matching, as I just mentioned, according to the goals and measurable outcomes. And there will be something like a contract, not a contract, but there's a kind of an agreement to maintain the sustainability of the mentorship project between the mentors and the mentees. There will be, so the mentor and the mentees has to participate in the bi-monthly meeting of the Supportive Care Network. And that's kind of like a feedback, kind of any of the pairs have any questions or anything. So I'll be the project coordinator all through, and any question from the mentor and the mentee is going to pass by me, and then I will be able to help. The third thing that we're going through right now with the SIOP office and other colleagues, that we are trying to arrange the meeting in SIOP for the mentors and the mentees together, and that's currently ongoing process, and we will update you with the mentorship, the final mentorship concept for those who are interested to participate. Second slide. So basically, the young physicians are going to be early to mid-career professionals with a specific interest, and this will go through the matching process. The mentors will be experienced physicians or healthcare professionals with expertise, and of course, anybody who is willing to be a mentor and he sees this drive or passion in him. And of course, the most important, and I think this is the main success of the project, is the benefit and the commitment where the participants are going to commit to regular communication and engagement all through the program duration. And we will be sharing the exact program duration with the mentorship concept note, which is going to launch probably after the launch of the application, the next 2 weeks, or after the SIOP meeting at the end of October. Next. So that's the organization structure of the project. So I'm going to be the coordinator, and Miguel Caniza will be the program advisor, and of course we get the support from other from all the supportive care network members who are going to be advisory, who are going to be helpful, who are going to be supporting this project. And also the transversal advisors, the Global Health Palliative Network. We have also support from the Global Health Network, and especially the palliative care team. And thanks to Mirai and Michael for supporting this. And fortunately, we have received like emails from our SIOP. I can't say leaders, but our SIOP. Very, very great SIOP members who are willing to be mentors and to help people, help in research, help in education, help in career advice, help in how to write an abstract, which is very simple, and a lot do not know how to do that. You can have a mentor from the United States and you're in Africa, and you can have a mentor from you, a mentee from Europe, and you're in Latin America. Depends on how we're going to match it, and depends also on what the mentee needs and what the mentor needs. And again, this project is kind of facilitating communication within the SIOP network and helping people to reach out to each others. More details about the application we're going to share with you in the next 2 weeks probably, and then the matching process we will do just after the SIOP annual meeting. We will also be sharing about that at the Supportive Care Network meeting during the SIOP in Honolulu, and waiting to see you all, of course, there. After that, there will be a concept note for the mentors, as I just mentioned, and also for the mentees regarding how can they benefit. Depends on the mentor's assignment or the mentee's interest in whatever they want to do. So that's simply. And of course, I'm here for anybody who wants to ask. Like, I'm going to, I think my email is on the Supportive Care Network, and I'm also going to, we will communicate with emails through the SIOP office soon. And that's it. And I would love to hear if anybody wants to ask whatever questions. And I think we have. Anybody just want to ask like any question right now till we share further more about the project in the upcoming weeks? Thank you so much, Dr. Scott, and thank you all for participating in the launch of such a project that has been so difficult actually to launch, but at the end we're going to achieve through it, and we are going all to help each other and connect to each other. And thank you so much.
Thank you, and thank you all. Great to see you here. Here's a hug, which I will deliver in person in SIOP.
No, there is a question from Lorna. No, you do not need to attend SIOP to participate in the mentorship program. This mentorship program is going to be like an overseas mentorship program where you're going to meet your mentor overseas through Zoom meetings. You will assign a project, probably kind of a training, probably kind of like something that's going to be educative, something in life. It depends on how we're going to match the mentors and the mentees, and you do not have to participate during the SIOP meeting. Okay, thank you so much. And I would like to say bye to you all, and thanks. So the machine is saying great, thank you so much, and see you all in Honolulu, and see you all in our next webinars. and expect to hear and receive emails regarding the participation in the mentorship project, and furthermore regarding the enrollment and applications that are going to be on platforms so soon. Thank you so much.
Thank you. Take care.
Okay, thank you.